Tom,
Yes.
we're gonna have to adjust the instructions about nursing CE since LMS it's now health streams, and I don't know the process for education since LMS is gone.
Absolutely. Good
Okay.
call. Luckily, Carly's on here and she can help me craft some language.
This one is at core. Juliana, sorry. She worked at school at 13. She's still there. She was doing everything I say you could tell she was. First job was at Hudson. That's when it was fine. Because they're all of these they were. And there's this other one. It's been to do that since 2015. I'm like, why do you want stuff that I was talking about? There's another one works at Lowe's. I don't know if taking retail. I can't retail. She's early 20s. So. There's too much chatter. But,
Clearing stuff off my to-do list.
Is that what you're doing? Getting it all cleaned up?
Yes.
You always feel better.
All right, good morning. My name's Tom Moran with the Albany Med Trauma Program. We've got a great presentation today. We're going to be hearing from Dr. Mark A. Rapp from our Department of Psychiatry. Dr. Rapp is the faculty psychiatrist, Department of Psychiatry for Albany Medical Center. He's the vice chair for clinical services and the co-director for consultation psychiatry. Today he's going to be presenting on, hold on a second, assessing medical decision-making capability for today's regional trauma conference. So sir, if you want to bring your slides up.
How's that? Excellent. Good morning. I know this is a topic that all of you think about constantly, but hopefully by the end of this ordeal, you'll be at least a little more comfortable with this. And certainly this is the start of an ongoing discussion, I think. So just by way of disclosure, when I say I have no relevant competing financial interests, I do want to point out that I'm a practicing forensic psychiatrist, and so sometimes I'm called upon to deal with malpractice and similar work. So if anything, this is counter to my interests. And some goals and objectives have to do with explaining the relationship between informed consent and medical decision-making capacity. And you'll hear me go back to that point a couple of times. We'll talk about the key elements in medical decision-making capacity, and then look at a couple of reasons why your patient might not be capacitated, and then talk a little bit about implications. I want to mention I've also invited my friend and colleague, Chuck Carletta, who is AMC Counsel Emeritus. He is retired and now on our faculty, and he's here to keep me honest. So we have a question I just want to put in front of everybody again, related to this conference about how we understand medical decision-making capacity, and hopefully at least by the end of this will be easy to answer. So one of the questions I always bring up is, why'd the topic come up? Why was I asked to do this? And I think there's a couple of reasons. One is that providers are often uncomfortable with these questions because they seem complicated and maybe remote from what they normally do every day. And worse yet, the implications of the answers can be murky. That is, sometimes people feel more comfortable answering the question than knowing what to do with the answer. And one of the problems is there's a lot of myth and misinformation that persists around these topics, and I think is a real disservice to providers. And of course, the other problem is that relatively few physicians are lawyers. This is a part of the world where we start to get uncomfortable. It starts feeling like we're in somebody else's sandbox. And for those of you who have an interest in the history of informed consent, this is not as ancient a concept as you might think. The phrase is first clearly used in its current legal and medical sense in the late 1950s in a case from California where a patient who had advanced cardiovascular disease was offered a procedure, an aortogram. This was 1957. And he suffered hemiparalysis because of the procedure and sued Stanford University. I think he recovered something like 2.3 million in today's dollars. And the reason was that they found that he wasn't adequately informed. And the judge in the case said, a physician violates his duty and subjects himself to liability if he withholds any facts which are necessary to form the basis of an intelligent consent by the patient to the proposed treatment. So the judge is laying out a sort of test. So one part where you become liable is where you don't disclose something that's necessary for the patient to make an intelligent consent. The other, and important, is that the physician may not minimize the known dangers of a procedure or operation in order to induce his patient's consent. And he mentions recognizing that every patient is going to have some particular interests in particular aspects of the outcome. So he mentioned that the patient's particular mental and emotional condition is important and may be crucial in discussing the elements of risk. So some people may have sensitivity or value to risks that other people don't. And this is the case that's sort of cited as the modern basis for our concept of informed consent. Although it's really not the very first idea, it's the best articulation of the concept. And in case it ever comes up on a board exam or something, the earlier idea of consent period comes from a case from 1914. And the idea was that people have a right to determine what shall be done with his own body, and a surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damages. So this idea of consent is not as old as you think either. While 1914 is a while ago, it's not from the writings of Hippocrates. And without informed consent, it's battery, right? If you treat someone without informed consent, that is, there's a wrongful touching, it's battery. It's even potentially criminal. And this idea is important because we deal with patients who we recognize as having varying degrees of ability to understand what their condition is and what's going on. New York, of course, being New York, has actually defined the lack of informed consent, which is interesting. Not every state would start off with a double negative like this, but they define the lack of informed consent as the failure of the person providing the professional treatment or diagnosis to disclose to the patient such alternatives thereto and the reasonably foreseeable risks and benefits involved as a reasonable medical, dental, or podiatric practitioner under similar circumstances would have disclosed in a manner permitting the patient to make a knowledgeable evaluation. Boy, that is a mouthful. But this is also telling us something interesting about the concept in New York. They're sort of measuring your performance against this hypothetical, similar, reasonable practitioner, right? So the standard is at least meeting that bar, but then it also articulates another standard. It says that the manner of disclosure lets the patient make a knowledgeable evaluation. And we're going to get into the weeds here in just a moment. By the way, show of hands, don't worry, I know it's on video. Show of hands, who here has ever gotten written informed consent from a patient? Okay. So the idea of informed consent is to honor the principle of autonomy, as we all know, an important part of medical ethics, and one of the duties we owe to patients. And one of the concepts here is, well, what are the ingredients? What are the parts that are in here? And one of the standards is called the reasonable patient standard. I want to point out for anybody who has doubts that the concept of the reasonable patient is an abstraction. Sometimes there are legislative standards. For example, there are some things that expressly require written informed consent, whether or not you would otherwise get it. So for example, HIV testing in some jurisdictions requires written informed consent, most actually, and certainly in New York. There are other things where there's a piece of legislation that says specifically that you have to have written informed consent. And there are also medical ethical traditions. So for example, we might get written informed consent for a vaccine. We might get written informed consent for a certain procedure, but perhaps not others. And getting back to what's involved, that is the ingredients, the objective standard, that is the reasonable patient, is an abstraction. The reasonable patient is in the head of somebody in the law, that is perhaps a jury, perhaps a judge, but it's not as if they test against a crowd of patients. What would you have wanted to know? So it's an abstraction, and it's important to remember that it's not testable the way we physicians think about it. Sometimes there's what's called a subjective standard, and for example, the law might require that you disclose what you believe would be material to the patient's decision to agree or disagree. That is, to take into account the specific circumstances of that patient in order to make a disclosure of the information. And for those of you who raised your hand, you must already know how to assess medical decision-making capacity, because the ability to participate in and give informed consent to a medical procedure is medical decision-making capacity. If you allow your patient to sign that they have read and understood, you must genuinely believe that they are capacitated. So we're going to go through the specific ingredients of medical decision-making capacity so that we're all on the same page. It's important before I do that, though, that you understand something that's going to be a little bit lawyerly, but it's something that we all have to understand. Adults have a rebuttable presumption of capacity, and that idea is that until you can make an argument that they don't have capacity, they do. That is, the burden of proof is on the person who's asserting that they're lacking capacity. Unless we can make that assertion, we assume that they are capacitated. Minors are different. Minors are generally presumed to be incapacitated, but sometimes there are specific exceptions. They're often about reproductive or mental health decisions, and they're sort of carved out. And they may also be graduated based on age. So for example, a 17-year-old may have a presumed capacity to do things that an 8-year-old doesn't. But usually minors are considered without medical decision-making capacity with those exceptions in place. So let's talk about how to actually make the assessment of medical decision-making capacity. And in the late 90s, a group led by Thomas Grisso and Paul Applebaum got a massive MacArthur Genius Grant and decided they were going to answer this question by coming up with the least complex model possible for making an assessment for medical decision-making capacity. The tool they used is still out there, the MCAT-T, and they also published a book, which I've always asserted should come stapled to your diploma, called Assessing Competence to Consent to Treatment. Just a word, by the way, you'll often hear people say that capacity is a medical decision, competence is a legal decision, but you'll also find that in a lot of places, the law is starting to use capacity more often than competence. So they're not interchangeable ideas all the time, but often. So if we look at the basic ingredients of medical decision-making capacity, there are 4 areas that Grisso and Applebaum identified. And again, their job, as they set it out, was to make the minimum kind of model. And that minimum model has these 4 moving parts. So it's meant to be as simple a model as possible. Some people find that it's not adequately complex. Some people add to it. But generally, if you read Grisso and Applebaum, they really did think of a lot of the objections that people have. And for our purposes, I think it's a reasonable way for us to proceed. So the 4 elements are choice, information, appreciation, and reasoning. And we're going to beat those up in shortly. But I want to point out that these are things that people can do. The capacity idea is the ability to do a thing. And these are abilities. These are things that patients can demonstrate. It's also important to me that we talk about what the patient demonstrates, because it's possible that someone can do something that they refuse to demonstrate for you, which gets us to some other complexities later. But the important part of understanding medical decision-making capacity in this model is these abilities are hierarchical. That is, you don't need to go on to the next thing if they can't demonstrate the first thing. So for example, if a patient cannot form a choice, can't or doesn't express or demonstrate reasonable consistency with the choice, then you don't have to worry about information. If you just can't get to the part where the patient can make up their mind or even say what they want, that you don't have to go on to start assessing the information that they have. You're not going to get there. If the patient can give you some reasonable demonstration of the information, you can go on to appreciation, but if they can't, then it's not really relevant how they apply that information to their choice. If they can't get the appreciation, then you don't need to go on to reasoning, etc. And I just want to make this point because it makes my job easier and it may make your job easier if you understand it this way. So if choice is the outer layer and you can't get through choice, you don't need to worry about information. That is, information is entirely enclosed by the choice task. If you can't get through information, you don't need to go on to appreciation. It's entirely enclosed. And of course, if you can't get through appreciation, you don't go on to reasoning. So it's important to recognize that if you think of these choices as hierarchical, if your patient cannot demonstrate the first task, you don't need to worry about the other three. So let's talk about choice for a minute. And I also want to mention that the idea here is also inclusive of the idea that it is a choice, that it's not coerced or under duress. And if a patient cannot express a choice, they're incapacitated. That is, someone who is entirely deprived of the ability to communicate with you cannot share their will with you. They cannot express to you what they want. That makes them incapacitated. And some people may not be able to do that because they literally can't arrive at a choice. For those of you who have seen, for example, psychotically ambivalent people, they may not be able to make up their mind. They can't give you something to work with. They can't give you a choice to work with. They're incapacitated. I think it gets a little tricky with my next point, so I want to be very clear about this. The patient's choice has to be clear and consistent enough for you to rely on. If you are deciding yes or no, are we going to do a procedure, someone who says maybe isn't giving you useful information. Someone who changes their mind every 3 seconds is going to be awfully hard to work with respect to their decision. So people are allowed to change their mind. People are allowed to come up with a different choice, but they have to be able to do so in a way that you can rely on. Otherwise, if it's so rapid or arbitrary and doesn't demonstrate the rest of the capacity elements, then they are probably incapacitated. So choice is the foundation. They have to be able to share their will with you. You are presumably acting in accordance with their wishes. If they cannot or will not share that with you, then you can't consider them capacitated. I think another area that is sometimes frustrating for providers is, what do we mean by information? How do we know it's enough? What parts are relevant? So with respect to medical decision-making capacity, it really is, what does the patient know? It's not what you have told them, it's what the patient knows. These, of course, alas, are different things. And a good way to think about it is, at a minimum, can they say, what do they have? What's the disorder? What's the condition? What's the injury that they have? And it's also important to say, well, what'll happen if we leave it alone? If we don't treat it, what's likely to happen? What are the worst things that can happen? And you don't have to have a great imagination for this, but you have to be able to think through, if something horrible happens 1 in 100 times, is that going to be relevant enough for someone to include in their medical decision making? And 1 in 100, the answer is, if it's really horrible, probably. The other is, what are you recommending? What's the treatment you're talking about? And I'm sure that some of you have had the experience of thinking that the patient is on the same page, only to find out later that they really don't understand what it is you're offering. not only are you talking about the treatment, but what are the likely and possible benefits and risks of the treatment? So again, you don't have to consider every conceivable possibility, but you have to think about what a reasonable patient would want to know, and especially what would you tell them that would have them make a different decision? That is there something about the procedure that might dissuade them or cause them to make a different decision than the one they're making? And it's important to be reasonable about this because, for example, the patient might need to know that you are invading a compartment of their body, but they might not need to know what kind of suture material you're using. They might not need to know which knot you're going to use. There are things that are specific and reasonable, and there are things that most patients are really not going to change their decision based on. And it's also going to depend on the patient, but we're going to get back to that. I think another thing that can be confusing is the idea of what are the alternative treatments you're not recommending, including risks and benefits. And there may be times where this is especially important. For example, if you have a case of a patient who is entertaining different chemotherapies or different kinds of treatment, there may be several options for the same condition, but there are also times where there aren't really reasonable alternatives, or at least not reasonable enough to include. And you don't have to make things up. You don't have to imagine things that no one would ever recommend. So I think where there are alternatives, they have to be disclosed. But where there really aren't alternatives, you don't have to strain your imagination to come up with something. I think a lot of people are tripped up by the idea of appreciation. And I think that a good way to think about it is, what does the patient's choice mean? What are they getting at? And by that, I mean, if a patient is able to tell you their goals and what they want, and then apply that information, they're probably capacitated. But you can have other kinds of problems that arise. So, for example, what if a patient just doesn't acknowledge the presence of their disorder or condition? I would want to know why they don't believe they have that condition. And there have been times where I have been surprised. I recall one case where a patient said, I understand what you're saying about repairing this fracture. I understand how it would proceed, but doctor, did you notice that's not my name on that film? It's not just the presence of the disorder, though, of course, it's the consequences of the disorder too. So I think as our patients increasingly have discovered medical resources on that treasure trove of truth that is the internet, there are people who may not acknowledge the consequences of the disorder because they have found alternative information. And they may have a reason to believe that the consequences are not what you think. I think it's also important to think about your particular offer. That is, what treatment are you offering? And do they acknowledge the possible benefits of the proposed treatment? So if you're suggesting a course of treatment and they say that they don't want it because, one of the things you want to know is, why is there that gap between what you're offering and what they think is going to be useful? So lack of appreciation is in one way or another about relevance. That is, you've revealed information, you demonstrated that the patient has at least absorbed that information, they can register and repeat it, but they're saying it's not as important or not as important to them as you think it should be. And again, it can range from a subtle kind of disagreement all the way up to psychotic denial. Reasoning can also be slippery, and I want to be clear that don't worry, we'll talk about more specific ways to think about reasoning. So a good way to think about reasoning is you can test this by simply saying, hey, why make that choice? Why is that choice better than the alternative? This makes a lot of sense and is not a bad thing to think about asking, even if the patient is agreeing with you. hey, why this instead of that? Their answer to that might make it really obvious that they're understanding very well what's going on. It might also make it obvious that they're not. So the reasoning that the patient has to show is logical processing of information in light of appreciation. So patient says, I want X and I'm willing to do Y. It ought to make sense. They ought to be able to explain to you why they're making the choice they make in light of their goals and preferences. And the degree of reasoning is also going to depend a lot on the nature of the choice. And we're going to get to that shortly. So since a lot of us were not raised to doing symbolic logic on a blackboard, I guess a whiteboard nowadays, we're not talking about the patient pulling out a formal argument that's named after somebody, but we're talking about being able to show you that they can do particular things. Can they focus on the problem? So, Doc, you're saying if X, then Y. Can they show you that they've considered the options? So, Doc, you're saying if I do X, then I won't have to worry about Z, but if I don't do X, then Z will surely happen. Can they imagine the consequences? Can they say, so you're saying I could have massive system-wide organ failure and die, as opposed to I might get a little sick? And a way to think about it is, are they considering probability and likelihood? And you will sometimes see people use the idea of badness versus likelihood. So something that is really bad but happens almost never is going to be weighed differently than something that's really bad and is highly likely. And what you want to see is the patient deliberate. You want to see the patient be able to say, so you're saying, Doc, you want to do this so that I can avoid that, and the risks are these. That would be an excellent example of watching someone do reasoning. I do want to point out, though, that medical decision making is potentially complex and emergent in the sense that someone who just has a preference is obviously not automatically capacitated for a particular medical decision. So just being able to say, I want to do this is not enough. Certainly, a patient demonstrating that they're oriented is not enough. Likewise, you can be psychotic and not have a problem with medical decision-making capacity. I want to repeat this. The mere presence of a psychotic disorder is never enough to disqualify someone from their medical decision-making capacity. If you have schizophrenia and you believe that all the angels are dead, that doesn't necessarily impact on your ability to consent for an appendectomy, as long as you can demonstrate those abilities, which are sufficient to get the appendectomy. If you believe the appendix is the seat of the soul and you can't live without one, that's a different problem. But if the psychosis doesn't touch on the task at hand, it's not actually relevant to their ability to make a medical decision. I cannot emphasize enough that medical decision-making capacity is specific to a particular task. When we talk about capacity, we're talking about an ability you can demonstrate. So for example, you may be capacitated to tie your shoes, but it doesn't mean you're capacitated to design nuclear reactors. You may be capacitated to drive a car, but it doesn't mean you're capacitated to fly a 747. They're task specific. And the more specific you can be about the task, the more likely you are to get an accurate answer. Another problem that people sometimes run into is that medical decision-making capacity is right now. It's present-centered. That is, if you are talking about an ability, you may have it now, but not later. For example, you could become delirious. Or you may not have it now, but gain it later. For example, a technical skill or the ability to demonstrate reasoning. A lot of people are uncomfortable with my next point, but usually it's because they're not lawyers. But I want to perhaps present this in a way that's easier to understand. Medical decision-making capacity is inherently asymmetrical. That is, agreement is not the same as refusal. And if you think about this for a moment, this is an obvious point. So if you offer a life-saving treatment to someone and they say, well, doc, I want to live, and you're telling me that without this, I won't live, then I want this. That's kind of boring. That's pretty obvious. The really interesting response would be, I want to live, you're telling me I need this to live, but I'm refusing this. That kind of requires some explanation. So these are not identical tasks all the time. And it's important to remember that because these are asymmetrical, one of the things to remember is because it's a rebuttable presumption of competency, the boring answer is much more in favor of a capacitated patient than the interesting answer. The interesting answer deserves more explanation. And they also depend on the task. And I think it's fairly obvious when I make that point, but sometimes people feel a little confused about how to think about that balance. So the task threshold in medical decision making is, can people sort of demonstrate their ability to think about the ratio between risk, benefit, and probability? So for example, if you have a high risk, low benefit decision, that probably requires a very high capacity. For example, participating in research that has no possible direct benefit to the subject and might cause them pain or permanent injury, if your IRB would even consider it, that's going to require a whole lot of signatures. That's going to require a whole lot of capacity because the ratio is not in favor of the patient or subject, as the case may be. Surgery that is really cosmetic, that doesn't have another point, might be a higher risk, lower benefit than, for example, a life-saving surgery, although that also has to be considered in light of what it means to the patient. And because we value freedom and autonomy, the threshold to work against a patient's wishes is actually pretty high. And sometimes for some of the decisions I'm involved in, you have to think about the idea of, are we really going to proceed against this patient's wishes? Does everybody imagine that we're going to hold this patient down and inflict this treatment they don't want? And it's important to give that some thought before you take other steps when you're thinking about whether or not your patient's capacitated. Or to put it another way, this is all about context. Context is paramount in making capacity decisions. So I thought I'd use an example, and I don't think it's a very complicated example, but I thought I'd share this just so that we can see if we're all on the same page. So let's imagine there's an older patient with community-acquired pneumonia. She comes in and receives antibiotics and suffers a renal injury. And while the renal injury is expected to improve with time, probably weeks, but probably not months or years, the patient requires hemodialysis, and the provider discloses the following. They'll need a dialysis catheter. They'll need probably 3 times a week or every other day hemodialysis while their kidneys recover, and information about hemodialysis, how long it takes, the kinds of effects that they might be subjected to, cramps, fatigue, that kind of thing, and also the time it will take. It's important when we think about these decisions, though, to make sure patients understand the setting. So for example, someone might say, so I'm going to be in the hospital until my kidneys recover? Well, no, we can also do it as an outpatient. Oh, so I can take my trip to Hawaii? Well, maybe not. So discussing the precise details really matters, and making sure the patient understands some of the limitations that the treatment may place on them. For example, not only would they get hemodialysis, but they would have frequent laboratory testing and close follow-up care. And assuming that their kidneys recover, the catheter would be removed, right? So they might want to know that they're not going to have this piece of plastic for the rest of their life. And it may be important for them to understand that removing it will leave a scar. So with that as our background, let's ask this. The patient doesn't communicate. Is this patient capacitated? Hopefully we all understand that the answer is no, right? You can't rely on this patient's will because the patient does not express their will. So while you may have stood at the bedside and revealed all that information about hemodialysis, if they don't communicate in any way, there's not a choice there. There's nothing for you to work with. And so this is a patient who is, at least without more, this is a patient who's incapacitated. What about someone who says, I'm not sure? And I'm sure that comes up for most of us. It can be very frustrating for busy physicians, but let's assume for a moment that you start off with, do you want hemodialysis? I've revealed all this information about hemodialysis. Do you want hemodialysis? The patient responds, I'm not sure. One of the things to do is to start talking about what's going on. Hey, why have they recommended hemodialysis? They tell me my kidneys have failed. Okay, good. We're on the same page. Why have your kidneys failed? That may be very important or less important. I came in with pneumonia. They said that plus the antibiotics might have hurt my kidneys. What will happen if we don't do anything? What will happen if we don't treat your condition? We expect patients to understand, at least at some broad level. For example, the patient might say, I guess I might die, but maybe some understanding of the timeline, because last I checked, we're all subject to mortality. A patient understanding that they might die over days and weeks rather than minutes or years might be an important part of assessing their capacity. Talking about, hey, what are we planning to do about it? What has been offered? Someone who understands that the offer is hemodialysis to replace the function of my kidneys and keep me alive, that's not bad. You're reasonably happy with that. And also demonstrating that you're on the same page with respect to expectations. We can be wrong, but we have to reveal what we know at the time. So for example, if we say, well, how long will you need this treatment? A patient who says, I don't know, they're not sure, but they expect my kidneys to improve, is pretty close to being on the same page. And also understanding what hemodialysis is. Patients don't necessarily have to know everything. So for example, a machine that they run my blood through that takes out stuff is not the worst explanation you're ever going to get about this. And it's not perfect, but it's a good start. And revealing to the patient what they can expect. They can expect that it will take hours. They can expect that they may feel fatigued afterwards. They can expect that they may experience cramps. Someone who can conclude, so I think it would be inconvenient and unpleasant, I guess, but if I don't do it, I might die. We're pretty sure that we're close to the same page. And if necessary, you can even say, well, okay, so you might die if we don't do it. What do you give up if we do? And someone who says, well, I see that this is a significant commitment in time. I see that it might be unpleasant to get hemodialysis. I don't know how long it will go on, which is a great point in this clinical scenario. And someone saying, on the other hand, it'll keep me alive and I want to be alive. You're pretty confident that this is a capacitated patient. But let's talk about something that comes up much more often for me and my people. I understand hemodialysis, doc. I understand that it uses a semi-permeable membrane that my blood would pass through as it's pumped by a machine. And I get that it could keep someone with kidney failure alive indefinitely, but I don't have kidney failure. You're going to want to ask, why do you believe that? We're all telling you that you have kidney failure. There's been a nephrologist here. There's been other doctors here to talk to you about that. And your patient might say, well, I'm still making some urine, so my kidneys must be working. There's a problem here, right? So if you're watching their potassium pile up and they're making their argument, well, I have some tiny amount of urine output, so it must be okay, you're going to want to try to address that. And one of the ways, so why are doctors telling you you need hemodialysis? And they might say, I don't know, but I don't have renal failure, so I don't need hemodialysis. You want to think in all of these cases, especially an example like this, where's the problem? What are they able to do? So just thinking about this simple scenario. This is a patient who can make a choice. I don't want hemodialysis. This is a patient that has information and maybe even some pretty sophisticated information, but the problem is appreciation. The problem is they have a belief that they don't have renal failure because they're still making urine. Kidneys make urine, they're making urine, therefore their kidneys must be okay. So this is a problem about what they're doing with information. This is at the appreciation level. And it's worth thinking about how you would address this. So speaking of how to address this, once you have made a decision about medical decision-making capacity, you're not done. And this gets us to a fairly large garden of other possibilities. And I just want to talk about some other kinds of ideas that are going to be important. So one phrase that I'm sure all of you in the trauma business have heard is implied consent. And this is an idea that a patient, without sort of explicitly giving informed consent, can make a decision that suggests strongly that it's something they want. So for example, courts have found if you get on a line for a vaccine and you stand in line and watch the 100 people in front of you get a vaccine, you're probably trying to get a vaccine. We also use the doctrine of implied consent when someone has an injury where we think they're not going to be able to express their will, where time is of the essence, and where we might say, you know, almost everybody would want us to save their life. Almost everybody would want us to perform whatever's necessary to keep them alive. There's also an idea that's sometimes referred to as incompetent assent, although this is a very old term. And the idea is a patient can be agreeing with you without really demonstrating medical decision-making capacity. And that can be an uncomfortable spot because you want to think about what that means. And of course, it means that you're probably moving on to surrogate decision-making or substituted consent. And there's lots of different ways that this branches off. You might have a healthcare surrogate or a power of attorney. You may have a guardianship. And it's worth thinking about when you have a patient where you're looking for a surrogate, are one of these other things true? Is there someone else who's empowered to make these decisions? I want to point out that there's a couple of decisions, though, that are very complicated because they're special cases that are legislated. So, for example, your surrogate could agree to epilepsy surgery where they remove a considerable portion of their brain, but your surrogate cannot agree to electroconvulsive therapy. And just as a disclaimer here, I'm not a lawyer. I'm not trying to dispense legal advice about this, but I'm trying to talk about the medical practice that I think informs the law. And we want to talk about some ground rules. So New York, by the way, to be clear, this is New York. This is unique to New York and not true in every other possible jurisdiction. In the hospital and some other settings, the Family Healthcare Decision Act sets up the guidelines for making an assessment of capacity and also talking about who can be a surrogate, when you need a surrogate, and how to use a surrogate. So for those of you who are a little pressed for time, it's a quick read. It only has 30 different specific definitions of what they mean. I think it's just under 10,000 words. It's a quick read. But to save you a little bit of time, it's important that you understand that in the hospital, under the Family Healthcare Decision Act, the initial determination of medical decision-making capacity is by the attending practitioner. And the attending practitioner shall make an initial determination that an adult patient lacks decision-making capacity to a reasonable degree of medical certainty. That's how certain they have to be of their decision. The determination shall include an assessment of the cause and extent of the patient's incapacity and the likelihood that the patient will regain medical decision-making capacity. This is not delegable. This is something that is a duty of the attending physician. By the way, Albany Medical Center has a policy that declares that we support and abide by the Family Healthcare Decision Act. Don't worry, the policy is only 20 pages long. It's a lot of ground rules. And I think the important part is sort of understanding that if you call a psychiatrist and say, hey, tell us is this patient capacitated, there's a reason that our answer is going to be nah. And in New York, the attending has to do those things first. And it's important to recognize why, because you all are in the best position to assess medical decision-making capacity for that specific thing. By the way, this is a matrix for the Family Healthcare Decision Act that lays out under what circumstances and who would be the surrogate decision maker. I bet it's a little complicated. It's kind of small on my screen. But one of the things it points out is also to remember that patients may have prior oral or written directions about what they want, and that can count too. So a couple of things to think about. One is you're acting in good faith to either determine medical decision-making capacity or in some circumstances, even to act with less than perfect informed consent is going to be driven by how you're acting in good faith. And a good way to think about it, again, not a lawyer, but the public health law describes specific exceptions to or defenses to malpractice liability based on a lack of informed consent, which is informative to us. So, for example, it mentions specifically when there is non-emergency treatment, we're expected to have informed consent, which suggests that if there is emergency treatment, we're not expected to have the same level or the same kind of informed consent. So if the patient can't possibly consent and it's an emergency, that's going to be reasonable. That's going to be the kind of discretion we get to use. Of course, provided it's in good faith. And I think one of the things you want to think about is if there's an emergency exception, what exactly is an emergency? And I think it's hard to find a definition, but it's important to recognize, you know it when you see it, and as long as you act in good faith, it's probably going to be something that is taken into consideration. Again, this is the definition of the lack of informed consent. So in the real world, what do you do? And my advice is you recognize that a patient is incapacitated or imperfectly capacitated, and it's not an emergency, then the best thing to do is fix it. The best thing to do is make them capacitated. And there are different problems with different tasks. So for example, a patient who can't express a choice, can't come up with a decision, or can't come up with a consistent decision, you want to think about what's going on, but you probably want a surrogate. Maybe you can fix their delirium, their thought disorder, or their intoxication. But if you can't, or at least not in the time frame that's relevant to your care, probably time to think about a surrogate decision maker. If the problem is information, then provide information. And we know from various studies that this is often the biggest problem. Patients don't absorb as much as we think they do. And sometimes the problem is that the patients don't really know. They might be able to repeat some things, but they don't really know what's going on. And so we decide that they're incapacitated. I would say that for both information appreciation and reasoning, the best solution is information. And it may help patients understand a little bit differently. And you can say, I would also mention arguing a little. If someone says, well, my kidneys are making 3 mils of urine a day, so I must not have kidney failure. It's okay to push back on that. It's okay to say, okay, I see why you think that, but let me explain why that's not enough to keep you alive. And failure to educate should not be grounds to get a surrogate. Failure to educate should not be the problem that results in us treating the patient as if they're incapacitated. And in emergencies, as I said, act in good faith, but don't forget about advance directives. And where it's not possible to get consent, look for surrogates. At least look for consensus. The more people who agree that it's reasonable, the more people who see why you're doing what you're doing, the better off you are. And implied consent is relevant, but it's not the be all and end all. So the more people are on the same page, the better off you're going to be. And I always like to quote Phil Resnick, a famous forensic psychiatrist, you should preserve the patient for litigation if you can. I, of course, would also like to share in the last couple of minutes my gripes from being a CL psychiatrist in many different jurisdictions. Since the Family Healthcare Decision Act requires the attending provider to make an assessment first, the place where a psychiatrist is relevant is where that attending physician has decided that the patient is incapacitated because of a mental illness. Then I'm a perfectly appropriate phone call. And that's a concurring opinion under the Family Healthcare Decision Act, which may or may not be necessary, depends on the circumstances. There are circumstances, however, where, for example, someone has a neurodevelopmental disability where I cannot be your concurring opinion because it's tightly controlled in New York. If you ask about assessing medical decision-making capacity, we want to know what's the particular decision. What exactly are we trying to achieve? So if you leave it very broad, it's hard for me to assess every possible decision. And one of the things you will often see with me in my service, the best way for us to do that is if you're going to do the usual informed consent that you would for that procedure, we'd love to be along for the ride. That's the best way for us to make an assessment. I also want to mention that you are not able to be neutral. So for example, you can't say, well, I think the patient's capacitated, but I want you to assess them. Well, if you're asking the question, you're putting your nickel down on thinking they're not capacitated. It's a rebuttable presumption, and you're offering data suggesting that they have a problem simply by asking the question. Also, neither I nor you get to decide on the surrogate. That is, there's a collection of laws or rules, depending on where you are, that usually decides the surrogate. And in a lot of jurisdictions, it's just a common law order, but more and more, it's a prescribed order of preference, and you don't get to just skip to who you like. And you want to be careful that we don't confuse our clinical assessment with legal action. Guardianship isn't up to me. I can't render a patient unable to contract, for example. So remember which part's medical care and which part's legal. Speaking of which, since there is guardianship, this is what a court has to decide in New York to get a guardian. This is a big production. I guess what I really want to say about guardianship is it's not your friend. This should be a last resort. We should not be looking for guardianship every time we find a patient incapacitated. And this is a big deal. It takes time, it takes money. It's a much larger concept than mere medical decision-making capacity. And it should be the last thing we resort to. It's also something that a patient's family or a patient's friends might be able to pursue as well. And we should probably avoid being the ones who become most involved. And as a nod to my friend, Mr. Carletta, I'd say get legal help for legal questions. If you're asking about guardianship, this is drifting out of medical care and well into legal problems. And the best thing to do is talk to counsel about what to do next. Anyway, thank you for your attention, and I hope you survived this ordeal.
Hey, Dr. Rapp, this is Dr. Edwards. Can you hear me?
Yes.
All right, great. Hey, I'm sorry I had some technical difficulties getting on. That was a fantastic talk. I just want to let you know that I want to open it up to the region, but I do want to put, just before you get off, some scenarios that I think are, put you on the spot a little bit for some scenarios that I think are pertinent to the region. Is that okay?
Of course.
All right. So the first scenario is in the pre-hospital setting. Motor vehicle crash, patient comes out, I loved your talk about, you gave me the source of determining capacity. It's my responsibility as the attending. And I really I'm going to put it on our trauma webpage, those 4 points that you said. I think Applebaum's book.
Rizzo and Applebaum, yep.
Yep. I completely agree that having those, going through that process, which is not a behavioral medicine or psychiatrist responsibility, but the attending physician, I think was fantastic. But the first scenario, EMS comes to scene, motor vehicle crash, patient sustaining significant injuries. They come upon the scene. Alcohol is smelled within the vehicle. There's laceration to the head. Patient looks like they have sustained a pretty high vehicle crash. Says, I do not want to get in the ambulance. I do not want to go to the hospital.
Yeah.
One is, and I want to say that the ratios that you were talking about, when a person agrees to do something which is expected, we all are pretty much saying they're capacitated. So that choice thing was really beautiful. But when somebody says, they're making a decision where they could have sustained a head injury and they could be impaired due to alcohol or drugs, now their EMS is out there in the situation. Where do they go there?
Yeah, I'm glad you asked that. I, of course, believe it or not, actually thought about questions like that. And one of the things I would ask, because I'm terribly pedantic, the patient's making an unusual choice, right? The guy who has just pried open the car door is saying, you've been seriously injured and you need hospital assessment and care. And the patient's saying, nah, I'm good, with blood pouring into their eyes. That's an unusual choice, and it deserves a very high bar for us to think that they're capacitated. And the smell of alcohol, smell is always dicey, but if you suspect that kind of impairment and you have someone who's not being able to explain that choice, right? If their choice is sort of, I don't want to go to the hospital, and then they, for example, say that your parents were never married, this is a preference. This isn't a demonstration of capacity. And I think under those circumstances, you have reason to believe the patient's impaired. You have reason to believe they're making a choice they might not make if they weren't impaired. And they're not showing you how they're weighing a serious risk against what seems to be a mere preference. So I think that's a case where it's pretty easy to be able to say, this is someone who's not capacitated. They're taking a chance that other people wouldn't take. They're taking a chance that we don't think they would take. And if we're wrong, what's the cost? We have imposed on their liberty. We may have run up their health insurance or even their own financial difficulty. But I think it's reasonable to see that as a case where they're very likely to be incapacitated. And the guy in the field is really talking about hospital care. They're not talking about any particular procedure, but they are talking about the idea of getting assessed for serious injuries. You already know they have some serious injuries. And I think that's a case where it's pretty easy to be able to say, I think I can act in good faith and say that this is someone who isn't capacitated, and it's reasonable for me to bring them to the hospital over their objection.
Okay. I don't want to take up all the time, but I knew that was one of the big ones. I have so many other questions that go down, but going through your steps where you did your circles, I think is very productive. And I know that, and these are usually about cases where patients in the hospital has documented injury to the brain, but seems to demonstrate all of those capacities, but is wanting to leave, and you understand and trying to communicate to them that could be a life-threatening situation if the brain bleed gets bigger.
Right.
And that's one that I see a fair amount, but I'm going to let this go open to the region because I feel like I might have stimulated some other conversation about that pre-hospital experience. So I'll open it up if possible. No, nobody else has any questions for Dr. Rapp?
In that case, can I just comment that someone who's in the hospital with a serious injury and wants to leave, that might be an appreciation problem, right? So they're saying my preference is to go home where my dog and my comfortable bed is, and you're saying, well, although the risk is let's say the risk of that bleed worsening is 50-50, just to keep our math simple. And on one side of that abyss is serious debility or death. And the patient says, no, it's a risk I'm willing to take. I would want to explore how they're making that judgment. So you're saying a 50% chance of dying versus being able to pet your dog. It would take a lot of explaining for me to feel like a simple yes to that was enough to end the conversation. And I think one of the perspectives to have is sort of how is our perspective on the scenario. So for example, observation under those circumstances, you might not know that the patient has, I don't know, a splenic capsular injury for sure. You may know that they do, but your period of observation is for a reason, and you have to weigh the value of that against their liberty, which is granted tough to do. But I think somebody who says, my substantial risk of dying doesn't matter to me at all, they probably have a lot of convincing to do.
And I think somebody put on the chat on that, but I also was fascinated with this point about surrogate, which I haven't really used before. So in that same kind of scenario, or maybe even in the pre-hospital setting, I don't know, person seems to have understand choice, have an appreciation that they could die if they refuse care or going to the hospital, express reasoning that there is a risk of death, and they're saying, well, you don't know that for sure. And you go, oh, okay, that is true. But I think that the conditions around here, the condition of the motor vehicle looked like you could have sustained a serious injury. And then going to saying, hey, they want to refuse that choice or that ride, or they want to leave the hospital. Is it reasonable to call a surrogate and say, well, can I talk to your wife and see if she's okay with this? Or
I think under those circumstances, the spouse is probably not in sort of an official position to make that decision on their behalf.
okay?
But I do think it's reasonable to invoke someone else who might also convince them that the risk of dying versus just going home isn't worth it. And I think the mistake we often make is sort of discounting the value of our wisdom and knowledge. So the problem there is still an appreciation problem, right? The patient is saying, well, you don't know that I have a serious injury. And I'm sure your, 30 years of doing this gives you a reasonable belief that they might have a serious injury and might have, say, a 50% chance of permanent debility or death. That's a pretty big chance. And you have to ask, how many reasonable people would say not going to the hospital is a reasonable choice under those circumstances? So I would be thinking about the appreciation element and saying, okay, so they have some information, but are they really plugging it in? Like not going to work on Monday because they're dead? It's sort of not well thought through. And given the stakes, I would probably be saying that's a good enough reason to say, look, I don't think we're understanding each other. Why don't I see if I can get your wife on the phone? I'll explain it to her and maybe you all can talk, depending, of course, on the time and what's going on. I don't imagine that you're going to have a colloquy and all of their neighbors gathered so that you can make a decision that's about a life-threatening emergency. But there may be circumstances where it's reasonable to sort of test it against their preferences. Now, if the wife gets on the phone and says, yeah, he hates hospitals, he never wants medical care, and he's always said that 50% chance of dying is okay with him, that's going to be harder. But I bet you don't have that phone conversation very often.
No. And again, the emergency, I think everybody out there on the region is pretty clear. Low blood pressure, a little bit of, person's not, but somebody completely alert and responsive and seems to have that initial assessment appreciation. That's the person that we, I think, or at least I struggle much more with. The person who's obviously impaired, slurring, is not oriented, is like, doesn't even know where they're at. Those are kind of easier issues for me to go, this person's incapacitated.
If I were in the field, I could probably let someone walk away if they can explain to me why taking a substantial risk on dying is more important than going to the hospital. But I think this is one of the places where maybe we're a little too meek thinking about our own expertise and training. So if we have a pretty good idea of how dangerous it is, and we try our best to convey it and it's not working, then what we have is a problem at the appreciation level. And again, someone saying, I'm willing to take a 50% chance of dying so that I can sleep in my own bed. I suppose we could respect that if they can demonstrate to us that that's really how they think and believe. That's going to be pretty tough.
Fantastic.
Another way to look at it, if someone has, for example, refractory cancer, and you're offering them fourth line salvage chemotherapy and they say, no, thank you. We say, okay, I understand that. I'm not offering you very much. If this treatment were to work, and it's very unlikely to work, it might buy you a little time, but it's also unpleasant. I get it. It's not hard to understand that. If we sort of flip that script around entirely, an otherwise healthy young person saying, I'll take a 50% chance of dying, it's kind of hard to believe that's what they really want.
No, that's why I definitely think that you had that slide up there about that it is asymmetric and it's also contextual. Like these capacities are, very much about what are we talking about. A young person, healthy, who might not want to get a DWI, who has alternative motives for trying to avoid hospitalization. Those are definitely that's why it's not simple stuff that we're doing out here in the hospital, out there in the pre-hospital. It takes an understanding when you're dealing with a patient who's choosing or making a choice, which seems, like you mentioned, very, not very what would usually be expected in the same situations.
And I think in the hospital, it's a good idea to get help when you can, and ethics will often be glad to be involved. They don't necessarily have to write a concurring opinion, although they can be one of the groups that can write a concurring opinion. Talking to legal, when you're not sure, it's never a bad thing to get some help. And again, if the issue is about mental illness, hey, we're here. But I think it's important to be thinking about the broader context, and especially that appreciation element. Someone who really holds their life lightly in their hands might respond differently from someone who doesn't, but they really should be able to convince you. They really should be able to sell, this is why my choice is okay.
So we've got two questions from the field. One is on the chat. For EMS, if a patient can't demonstrate capacity after those 4 steps, is there a good chance they should be 941 to the hospital?
No. And I'll tell you why. 941 is a police power that is for mental illness. It is not for medical care. That's not its purpose. And I think you want to be careful that we don't make this even more complicated than it needs to be. I hope that Mr. Carletta is not frowning at me. But I think it's important not to confuse these things. And really, a 941 is the section of the law that allows essentially a police officer to be able to bring someone to the hospital for assessment of their mental illness. So the important part there is that the officer believes they're mentally ill. An officer should not bring someone on 941 merely because they're intoxicated. Intoxication isn't a mental illness. A police officer shouldn't bring someone on 941 merely because they're dangerous. Dangerousness isn't a mental illness. So we have to be careful that we're kind of staying in our own lane with that. At the same time, I would take a chance of bringing this person to the hospital and saying, we brought you here because we thought you were not reasonably capacitated to refuse this hospital care. And if you could have demonstrated it, we would have done differently. That's part of acting in good faith.
And we've got a raised hand from Jennifer Peabody.
Hi, thanks. I wanted to ask a follow-up to something that Dr. Edwards alluded to. In a scenario like that motor vehicle accident, maybe someone doesn't have any obvious signs that they're incapacitated, but their reluctance to be transported is due to the cost, their medical insurance, or they don't have medical insurance. How do you handle that part of the scenario where you think they should be evaluated?
I think that some of the healthcare system issues are very complicated. My first thought would be, listen, we're talking about potentially your life and your health here. And while I appreciate that you could be stuck with a pretty big bill, the alternative could be that you die. And I think if you genuinely believe that, that is part of the educational process that we have, even in the field. Hey, there's a reason I think you should go to the hospital. On the other hand, it is also true that if someone has very minor injuries, or you think there's a very, very low probability of serious injury, you can't really force somebody to go and get hospital care if you genuinely believe those things. If, however, you genuinely believe that there's a high risk of serious injury, I think it's important that you share that with the patient and you see where you get to. And if someone can explain why it's a better idea not to go to the hospital, I think that you are stuck by abiding by the wishes of a capacitated patient. But that one's hard. Money and health perhaps shouldn't equate as easily as they do. But I think you need to share that with the patient.
Tom, I think
Thank you.
Mike Daly's put some stuff about that 22. A lot of people had a lot of interest, if you see on the chat.
So the other side of this that's interesting is mental health law 2209 allows law enforcement to take someone into custody if they are intoxicated or under the influence of drugs, and there is clear evidence of the potential for life-threatening illness or injury.
Right.
So that's really helpful if they're drunk. The problem is that when they're not drunk, they don't seem to have capacity. And now we're forced in a situation where EMS says, from a medical perspective, this person does not have the capacity to make a decision. From a legal perspective, there is no law that compels a police officer to assist EMS with bringing that patient to the hospital. This will remain a significant issue for EMS attorneys to continue to help guide us. I would say right now we've crossed that threshold from the white coat to the black robe that Dr. Rapp was talking about, and that the next step after this will be us asking our local EMS attorneys to do a follow-up conversation to this that we'll host through the EMS education platform.
And I have great news. The state of New York has a legislature that's so active that a politician who doesn't understand any of this is likely to pass a law that will make all of this worse. Wait, there was good news in there somewhere.
Well said, though, Dr. Rapp. Well said.
I know we went a little bit over time. Dr. Rapp, I can't tell you how much I appreciate it. Like I said, those foundational concepts that are on there, the family health law in New York State, very much about the surrogate, is very applicable as we're trying to go through this. and highlighting that it's attending responsibility. And as Dr. Daly has highlighted, I think it's spurred a lot of information in the pre-hospital arena, because trying to have somebody who is, GCS of 15, the oriented person who can demonstrate some of those principles, but seems to be incapacitated, trying to force them to get healthcare becomes a huge and imposing deal, with an uncertainty. Like there's a risk, but not a certainty. Like if there's a certainty somebody has arterial bleeding, it's much easier to say, hey, you're going to bleed to death right here if we don't do this.
But if the car looks like a pancake and it takes 40 minutes to get the patient out and there's evidence of serious injury, I think you can act in good faith and say there's a high probability of serious injury. You're suddenly much more reasonable.
Yeah. Anyway, Tom, you want to close this up? It's been fantastic. Dr. Rapp, I really appreciate it.
Happy to. And I also want to thank Mr. Carletta for joining us.
Does he have anything he wants to add? Oh.
He's shaking his head no.
Okay.
Well, thank you, Dr. Rapp. Great presentation. For those wishing to claim nursing CEU, please put your full name and credentials in the chat, and we'll hold the chat open for a few minutes so you can do that. If you're looking to claim provider CME through the Cloud CME system, please use the instructions that were sent out with the WebEx invite and use activity code 12198 to take your post test and claim your CME. Thank you for all your attendance. Again, Dr. Rapp, thank you very much. Everybody have a great day and stay safe.
Thanks for having me.
Thanks, Tom.